Oh wow, that's like the projector's like a spotlight. Wait for Sean, make sure Sean's got it live. Okay, perfect. Welcome everyone to our 10th annual Eastern Oregon EMS conference. We're super excited to be here. Technically this is the 11th, but with COVID we had to cancel, so we're calling this the 10th annual. So we are the committee. I'm Liz Wallatera. I'm the conference committee chair. Kind of interface with a lot of you on the email and on the phone. So I'm going to let the conference committee introduce themselves really quick and talk about where they're from or what agency they represent. Which one is you want both? Okay.
Sorry, one of our tech issues last year for those online was we weren't able to hear us very well. So we went with microphones this year. So hopefully the folks online can hear us. My name is Sean. I am one of the conference committee members, and I do help with the virtual online. And I'm currently working in the city of Camas, Washington, where I'm the EMS division chief.
Good morning, I'm JW Roberts, work at Umatilla County Fire District 1, been helping out for 10 years, the website and other conference duties.
Other duties as assigned.
Yep.
And I forgot to say, I work at St. Anthony Hospital here in Pendleton.
Okay. Sure. I'm Tracy Holliday. I am the trauma stroke coordinator for St. Anthony's Hospital.
Hello, I am Sarah Doherty. I am also from St. Anthony Hospital. This is my 6th year with this group, and we are so excited to be here.
Good morning, Peter Benjamin. I don't know how long these guys have had to put up with me on the conference committee, so I just show up every year and help out. Paramedic at Wallowa County over in Enterprise, Oregon.
Hi, Steve Roast. I work for Pendleton Fire Department, and I've actually been on the committee since the beginning, so 11 years.
Scott Matson, retired out of Woodburn Fire. Been on the committee 3 years, have attended all 10, I believe, 11. So glad to see you guys this morning.
All right. And Ian and Aaron are also from Lifelight on the committee, and we will probably see them later. So without further ado, we have just some quick housekeeping items. Restrooms are down the hallway. And then we also will have snacks, the coffee. Sorry about that. We blew the circuit breaker apparently back there.
My fault.
Blame Peter. So we will have coffee, hopefully ready after this session. Feel free to chat with the vendors. We gave you 15-minute breaks today. So as you're going down, talk to the vendors. They sponsor our conference. They give us money to help keep our costs down so that our tuition costs are pretty low. We appreciate them. Banquet tonight will be at the Roy Raley Room, and we will have a slide that shows parking. It's at the Roundup grounds. There's kind of a tan building that they have a banquet area. They donated the space to us. We have some alcohol that's been donated by some local vendors. So you have drink tickets, 2 drinks in your lanyard. They will check IDs. I know there's a few students here. So we tried to pull the ones we assumed were under the age of 21, but they will be checking IDs down there. Social hour tonight starts at 5:30, and then the dinner will be served at 6. People have asked attire. We say conference casual. Conference casual will look like this. Lunch today will be up in the Student Union building, so just the next building over. So, and that will be, I don't know what time, after the 3rd morning session. We do ask if you're outside visiting, try to stay away from the doors. We'll keep the door shut, but the noise really carries in and it's hard to hear if you're in the room. So just try to stay down the hall. Your booklet that is in your folder, yeah, everyone has your booklet. Make sure you put your name in it. And then after the end of the sessions, we will be on the sides and we will stamp the session, and that's proof that you were in that session, and then you can use that for your renewals. And then the categories are in there for whatever your research category is. So it'll have trauma, airway, breathing, cardiac, circulation. And then if you got an ODOT scholarship and haven't signed in up front, we do need you to sign in. We have to prove to ODOT that you were here and attended the conference. And then also you will see a BMCC registration form in your booklet or in your pamphlet. Please fill that out. That gives BMCC credit for hosting us, so they can count this as a student event and they get funding based on enrollment. And so they provide the college to us at no cost. It's really important that we give them that credit. And then one last thing, if you were in ABLS yesterday and need a stamp, just let us know and we will double stamp your booklet after this. We'll get the ABLS one after this. I believe that's all my housekeeping, and I'm gonna let Sean talk a little bit about the virtual.
All right, so those in the room, doesn't apply to you. For those of you online, the way you get proof of attendance is at the end of the session, you'll receive an email with a certificate of attendance. It goes to the email that registered for this. Please don't try to open that from your phone, or you'll email me and say, I can't see it. Only do it from my actual computer. So that's how we will do that. And for those online, you can use the chat or the question feature if you have questions for the presenter. And when there's an appropriate time, we will interject and ask those questions. With that being said, I think it's time for Tyler to get us kicked off with our first presentation. So I'll let Tyler introduce himself.
All right. Mic myself up. And if you could play my introduction music. Oh, I'm just kidding. No, I specifically said Back in Black. Hey, good morning, guys. Nice to meet you all. My name is Tyler Christofoli. I was sick like 2 weeks ago, and I still have not gotten my voice back. So I'm going to try to talk real loud, but I'm also in a band as a singer, so I got to rest my voice before a St. Patty's Day gig. So I'll be doing both, but you guys are going to see me a couple times throughout the next couple days. You probably got sick looking at my face on the Oregon EMS page as soon as you open it up. It was funny, I was at the hotel last night, and they're like, yeah, what are all these people for? And I'm like, oh, there's a East Oregon EMS conference. And she's like, well, what's it called? I was like, I think it's the East Oregon EMS conference. So she looked it up on the computer at the hotel, and she's like, oh, that's you. She's like, your hair looks more brown online. She said that. I said, yeah, the camera adds 10 pounds. And she said, well, how many cameras were on you? No, I'm joking. She didn't say that. Guys, this morning, I want to get into some stuff on training and how to frame mental models. So and you guys are like, what the heck is that about? You know, what is mental models? I'm a flight paramedic in Minneapolis. I've been a paramedic for about 15 years now, which is insane to me to think about. And this is, hopefully these slides all change. It might be a little bit of a delay. This is my son. I actually have 3 kids. This one's my favorite though. And that's only because he's obsessed with helicopters. He absolutely loves helicopters. We made him his own little flight suit with like his name on it. And my daughter wants to be a teacher and my son wants to be on a SWAT team. So they don't really care about the helicopter. But I got into flight probably 8 years ago. I spent most of the time working on an ambulance. I did the firefighter, EMT, AEMT, paramedic thing. And when I got into flying, I remember thinking like, okay, this is like the same thing, except you're just in the back of a helicopter. But there was like all these aviation side and like terms and IFR and VFR. And I'm like, it's interesting. Like they wake us up in the middle of the night, tell us to go on a flight, and we can say no. We could say, no, you know what? The weather just doesn't look great. Or on the ambulance, it was like, no matter what, you have to go on this. Yes, sir. Oh man, that's got to be annoying. Is it still doing it? Doing it? Oh, okay, perfect. So what I wanted to do was frame a talk on how I have tried to frame EMS in my head so that way I don't have to wait on experience, because coming in, 1-2 years, I'm sure some people in here have socks older than me and have been doing this for a long time, but I was sick of waiting on experience. And there's a couple situations where I was like, I don't know, like people would say you have to run a couple codes before you get really good at it. And I'm like, okay, but like that means I got to practice on people. And that seems kind of weird. I don't want to do that. And I remember it was 1 week as a new EMT, right? So 1 week we go out, we have a patient who is in cardiac arrest. And we drop a, I don't know, I think it was a combi tube or a King Airway or something. And we're ventilating. The patient, we get a pulse back. It's like awesome. You know, we finally get this pulse back. And I can't get the pulse ox. I want to say it was like 86, something like that. I could not get it above like 86%. And so I'm sitting there bagging them and I'm trying. And this is probably kind of hard to see in here, isn't it? Do you guys want to turn the, can we dim the lights just a little bit in here? Not really. Dim the lights down a little bit. I know it's getting dangerous. We got no coffee and we're dimming the lights. That's not bad right there. That's a dead old guy. If you guys can't see it. Yeah, that's not bad. Just it's still early enough. Nobody's gonna fall asleep. And so we're ventilating this guy. I can't get his pulse ox up. The paramedics come walking in. They look at everything and they say, "Oh, here, throw this on your BVM." And so they throw me a PEEP valve. And so I slide the PEEP valve on, and the pulse ox comes up to 94%. And I'm like, that took you like 2 seconds. I've been sitting here trying to get this guy's sats up for 5-10 minutes. Paramedics walk in. Here you go, buddy. So it's like they knew exactly what they were going to need when they walked in. I'm like, that's impressive. Like this one little piece of plastic that I hook onto my BVM increases the SpO2. You know, it increases the surface area. Do you guys use PEEP valves on your BVM here? There's a lot of places that are like, no, we're not allowed to. I'm like, you're not allowed to. Like I've seen patients completely turn around with this. So I'm like, oh, that's really interesting that's, you know, but you know why he knew it is because he's seen this before. He's walked into the same situation and he knew, yeah, when you need to increase oxygenation, sometimes you need a little positive pressure with it, right? So now let's fast forward to like 2 weeks as a new paramedic. And I go out and I have all these things I can do now, right? I have like medications and I can do crikes and I can cardiovert and, you know, I know how to, I've done them all on a mannequin, so I'm perfect at it. And we go out for a car, it was a rollover actually. And I get there and this guy's combative, he's yelling, he seems very intoxicated, right? And I can't get him out of the car. We've already called the helicopter. I got his arm that's like out like this, you know? So I'm like, oh, I'll start an IV. And, you know, he's yelling, he's in pain. I was like, I'll give him some pain medication. So I start an IV in his arm, you know, I give him a little bit of fentanyl and he's still just acting crazy. And so the flight team gets there, the fire department's trying to extricate him out of the car. And the flight team gets out, you know, they're walking with their hair blowing in the wind, you know, as they take off their helmet. And the first thing they ask is, what do you guys think they asked me right away? What did you say? Yes. What's his blood sugar? And I'm like, you guys ever see where people put WNL for within normal limits? And they say that stands for we never looked. I'm like, I don't know what his blood sugar is. So we go walk over and they're like, oh, do you guys have access to his hand? I'm like, no, I do. I started and I actually have his blood right here. I could have totally checked the glucose, but I didn't. And it was 40. So they're like, okay, well, you know, maybe after the fentanyl you gave, you could give him a little dextrose. And I'm like, man, like, I feel like I just keep fracking everything up. You know, I feel like I cannot have a call that runs smooth without somebody coming in and telling me something I should have known, you know? And I thought, what is it? Do these people have like ESP? Do they have some superpower that they're able to walk in and just immediately know what to do? And you start to think in your head, maybe I'm not cut out for this. Like, maybe this isn't what I'm supposed to be doing. How many of you guys in here would consider yourself a high performer? I don't see a whole lot. How do you classify? What would you say a high performer is? Because you would say somebody in the NFL is a high performer, right? But they don't all win every Super Bowl, right? They drop catches, they miss field goals. So what is a high performer? You know, and it's really a mindset. It's a mindset of learning from your mistakes. And I'm sure we've all known someone who's been a paramedic or EMT for 20 years, and it's been the first day every day. You know, it's almost like they have the blinders on to when it comes to self-reflection. But when I thought back at these providers that I had encountered, you know, just these few encounters I bring up, but there's a ton of them. The main thing between all of these is that they knew exactly what to look for. They knew what to identify. Oh, perfect. I ordered my Starbucks because I was optimistic as to whether it's, and so I thought, all right, you know what, dear diary, and I don't actually have a diary, but I like this picture. I said, dear diary, I do not want to wait on experience in order to perform well. Like, there's got to be a hack. What's the hack out there? Because I'm not practicing on people's family members while I'm trying to get good at this. You know, how long is that going to possibly take? I mean, we are in an age of AI and all of these different training methods, and there's so much good online education now, and we're still telling people, oh, you got to run a couple cardiac arrests before you actually get good at it. How do we fix that, right? When they were going in to raid, you know, where Osama bin Laden was, they had one chance to do that with the SEALs. They practiced, they drilled. They had never done that before, but they wanted to make sure when they did it, they had it down pat. And so how are you practicing the things that you've never done? I'm sure there's skills in here that maybe are within our scope that we've never actually gotten to do before. We've practiced them, you know, the high acuity but low occurrency skills, or what is it, high acuity, yeah, halo skills, but we haven't actually done it enough. And so I started thinking of when I was younger. So I grew up in Florida, and there was this place called Old Town. I don't know if you guys have ever been to this place, but they had a magic shop. And every time we had company, my family would take us to Old Town with the company. And I would ask to go to the magic shop, right? And so I go into this magic shop, and the guy had he asked my dad for a dollar bill, right? So my dad gives him $1, and he takes the dollar and he like crumbles it up. And then he just like goes like this. And it's like, this dollar is just like levitating in the air, right? And I'm like, okay, where's the strings, you know? And he takes his hand, he's going all the ways around it. He takes a cup and puts the dollar bill in the cup, puts the cap on the cup, hands it to my dad. My dad holds it, takes the cap back off, takes the dollar bill and hands it back. And I was like, I need this trick. Like, you know how many girls I could get in school with this trick? Like, I was like, I need this. And so, you know, for just, 3 easy payments of $50, you know, we'll take you behind the curtain and teach you how to do this trick. And so I came back, it was like a week later, you know, and I asked him to do it again. And he's like, weren't you in here last week? I was like, yeah. He's like, no, you don't get to see the trick again. He's like, you know, a good magician never does the same trick twice, you know? And I was like, man, how did you remember me? It's probably because I was drooling over the trick, but like, I thought, that makes sense, right? Why do magicians say they're not going to do the same trick twice? Well, that's probably true too. I got to reset it, right? I mean, the main thing, and back to contrasting what we've talked about so far this morning, is like I knew what to look for, right? So I knew he was going to make this fly. So anything that may have seemed like a, you know, stochastic event, a random occurrence, probably if he did it again, I'd be like, well, that's part of the trick. You know, you ever seen the trick where somebody takes a penny and they act like they're going to rub it into their elbow and they accidentally drop it? Oh, I'm sorry. Hold on. Let me do it again. And then they rub it and they drop it and then they pick it up with this hand and then they do it like this. If you do it twice, they're like, well, every time you drop that, that's part of the trick. And then you start looking into it. And there's actually magic trick like evidence out there. And they looked at how many times you have to see a trick before you come up with the solution. And by like the third time, you're able to start picking up exactly how they do it. And I thought, I wonder if that translates to training, right? If I come in and I have a cardiac arrest patient, maybe something went off, I was just oblivious to something. Second time, okay, I'm getting it. Third time, do I get better? You know, does that same thing translate? Because what we're doing is we're framing our brain to predict what's going to happen next. So we go in, I know if I have a patient with an ATV rollover and they're out in the woods and they say, we're going to take you on this UTV out there, I know exactly what I need to bring because of things that I forgot in the past, right? I know I need my suction. I know I'm going to need probably my blood. And so I can predict these things with patterns. And so history, they say history repeats itself, and it does in these patterns. And so I'm going to show you guys this clip. I hope the sound works. If not, I'll do the sound effects with my mouth if it doesn't. But I'm going to show you guys this clip, and I want you to try to figure out what's going on, all right? All right, so it's going right there. And it's not starting, right? I can do the sound effect again if you guys need me to. So, what do you guys think's wrong with the car? What's that? Oh, what do you think's wrong with my laptop? No, I don't know if it played through. Let's see. Is it? Turn the sound up. Oh, that's him. That's okay. It went, and so now I can. I'm gonna screw up my voice before I even get to the second talk today. I played this clip and I asked, what do you guys think is wrong with the car? And what do you think people say? Starter. I heard battery somewhere. What's that? Fuel. What's that? Long crank time is fuel. Yeah. See, like everybody's got these. Me, it's like, oh, this is Minneapolis in December. Like everybody's cars are click, 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 click. And so what I did is I took like the clip that the stock footage of somebody starting a car. I put in the sound of a dead battery, but I'm starting to believe this guy because of how he phrased it. And I thought it's interesting, within seconds, your brain is recalling stuff that had happened in the past that you've experienced and then bringing it to the forefront. I think it looks like this, I'm not exactly sure, but I think we have a predicted behavior. And then when that doesn't happen, we recognize that there is an abnormal behavior. And as soon as we see abnormal behavior, we start going, well, what the heck is wrong with this thing, right? So recognition of this abnormal behavior. And then right here, I believe, is where our mental simulation starts to begin. And, we're talking over the course of a couple seconds that we're doing this. And so the mental simulation says, has this happened before? And if it has, then we're going to start coming up with a working diagnosis. We want to know, well, what was the issue last time? What did we have to do? And that's likely going to be the thing that fixes it. Now, you can get yourself into trouble with this model too, right? Just because it's what was wrong last time doesn't mean that's what happened this time. Just because I've had a couple drunks who have rolled their vehicle doesn't mean that that patient with a glucose of 40 was intoxicated, right? So sometimes mental models can lead you astray, but they get the ball rolling because, and usually, as long as you have a loop where you're constantly reassessing and saying, is this expected? Okay, then I'm going to do this. They work really well. There's this book out called Sources of Power. It's by a guy named Gary Klein. Has anyone ever read this book before? So he is an American psychologist, and he's very interested in performance. He's interested in how people make decisions. He actually went out and he followed these New York City fire chiefs around. And he mentions in this one case where they got there, they had this big high-rise fire, and they have a protocol with how far they back up everybody, that's wanting to watch the bystanders. And this fire chief said, no, we need to get back even further on this one. And they're like, we're pretty far back. And he was adamant that everybody backs up. And so they all backed up, and one of the billboards on top of the building came off, fell, and would have killed exactly where those people were. And this Gary Klein, Dr. Klein says, if you were watching this, you would think that this was like a movie, like how this works. He was like, get back. And as soon as they all got back and he set it up, it fell. And everyone was like, how did you know that? And he was like, it comes from something called recognition prime decision making, where we have mental models of how we see things. typically based off of experience, right? And those mental models, if we pay attention to them, they can make us look like superheroes. They can make it look like we walked in and threw a PEEP valve to that new EMT and he knew exactly how to increase that pulse ox. Or you get off the helicopter and you see this car rolled over and here he's combative. The first thing you said was glucose, you know, because we've seen these, we've had these, you know, similar mental models. And what's funny is when you don't have a mental model, when you don't have experience on something, we resort to algorithms, right? Algorithms are created so we can do the most good for the most amount of people, but they don't always work. And I'm going to show you an example. So I go out on a call and I have a male party unresponsive. It doesn't sound like a fun party at all. I go out on this male party unresponsive and my mental simulation is beginning. What are some of the things that you guys have seen when you go out and you have somebody unresponsive? What are some of the problems that alcohol? What else? Drugs. I heard fentanyl, dead, you know, cardiac arrest, stroke. What's that? Yeah, so I'm starting to go through this, like anticipating what this could be. And so has this happened before? Yeah, it has happened before, but not a lot. I'm a pretty new paramedic now. So I get there, and this is what my EKG looks like. It's wide, it's slow, and I'm going, all right. You know, the heart rate, I want to say was like in the 40s, and I'll bring up the little heart rate up here real quick. Patient has a fistula in as well. And I'm sitting there trying to think, what is going on with this patient? Elderly, it was like, I want to say he was like in his 50s, 60s. He was old, yeah, like 50s or 60s. And I look, and his heart rate's 46, blood pressure is 71 over 30s, and no, I think it was more like 60, 70, I don't remember. And I said, well, he's bradycardic, he's hypotensive. So what do you have to do for those patients? Yeah, I see what, yeah, pace them, right? I'm like, all right, he's that's the algorithm. That's the algorithm, right? If you're bradycardic and you're stable, you know, then you could get some atropine. You could get atropine probably either way. Or you could start an epi drip or you could pace them. But an unstable, you know, hypotensive bradycardic patient, you're supposed to start cardioverting, right? So I'm like, oh, cool. I get to see if this cardioversion stuff works, or not cardioversion, pacing. I get to see if this pacing works. So I put the pacing pads on the guy and I start turning up my milliamps and I'm cranking it. I cannot get capture on this guy. And so I'm pretty sure I didn't get capture the whole way to the hospital. What's that? Push those epi. Yeah, we were looking at, you know, should we start an epi drip? I don't know. I mean, we're pacing them. Maybe we should change the pads a little bit, right? And so we get there and they come in and they gave him one medication that all of a sudden made his heart rate speed up. And it wasn't epi or atropine. What do you think it was? Meth. It wasn't mag, no. It was calcium chloride. And I thought this guy just had a really good AC. No. What is that? What is this right here? It's a dialysis fistula, right? Which means he's probably on dialysis. He was not able to tell me that. But if you have a slow, wide rhythm and a guy that looks like he's got a snake in his arm, then that's likely going to be what condition? Bingo, hyperkalemia. It is very difficult to pace hyperkalemia. But I haven't had that before, right? So I'm just following the algorithm. I have calcium chloride in my ambulance, right? I could easily have given him calcium chloride, but I was following the algorithm. His potassium came back and it was like 7.5 or something like that. And so the calcium doesn't shift the potassium, right? But it puts like that Harry Potter invisibility cloak over the heart and it protects it. It protects the heart by elevating the action potential. And I felt like the biggest idiot in the world because I'm like, I was sitting there trying to pace this guy And they knew right away, yeah, it's really hard to pace hyperkalemia. They gave him some calcium chloride, and then bingo, his heart rate came up, and then they do the insulin D50 thing to put the potassium back into the cell. And I was thinking, like, this is a perfect situation where the algorithm is made to do the most good, but it doesn't include everything. You know, it doesn't have all of those. And maybe you could say, well, if you considered your H's and T's, you would have done it, you know. But I had calls after that where I would come in and I would be like, we just had one. We flew in and they had a guy whose heart rate was in the 30s. They couldn't pace him, and they were waiting for the labs to come back. And I'm like, does he have a history of renal failure? And they're like, yeah. Does he take spirulactone? Yeah. All right, I'm gonna try something. And so I gave him just calcium chloride, and all of a sudden his heart rate came back down. And then they came back, they're like, well, the labs aren't back yet. I'm like, okay, but even if like calcium chloride, that's not that big of a deal, you know? That's like some IV Tums or something, you know? I'm like, it's not gonna hurt him. But I was like, I'm not gonna wait, because how many, you guys don't check labs in the back of your ambulance, right? So you're mostly going off of gut, right? We have EPOC in the back of the helicopter that we use quite a bit, but I did not have that luxury on the ambulance. And honestly, I'm not bringing that into the hospital with me. I'm not going to wait for those labs. If I see an ECG, I'm going to try that and see if that works. Now, there was a situation where we came in, and you guys have probably all been in a situation very similar to this, where we get a call for a vehicle that rolled, right? Person is unresponsive. I jump in the back, I'm doing the intercept, and they're getting ready to intubate this guy. And they say, or actually it was a female, they were getting ready to intubate. They said, yeah, you know, we were extricating her out of the car. She was complaining of pelvic pain. And when we got her out of the car, she went unresponsive. And so GCS less than 8, you got to intubate, right? And I said, no, just because it rhymes doesn't mean it's a good thing for the patient. But they're like, yeah, we got to intubate, right? So they go in and they got all their stuff set up. Patient's not controlling her airway at this time. What are some of your concerns when you look at these vitals? What's up? Yeah, low blood pressure for sure, right? Have you guys ever heard of a shock index? What is the shock index? Bingo, nice job, exactly. Yeah, the shock index. Is your calculator? Well, I'll be honest, I'm not good at math, right? But if this number is higher than this number, then that means my shock index is more than 1, right? And essentially what it's saying is your body's compensating for something. And so if you were elevating your heart rate just because you were nervous or anxiety, you would expect your blood pressure to come up too, right? You wouldn't expect your blood pressure to be coming down and your heart rate to be coming up. That's a compensatory mechanism when that happens. And so I walked in, I looked, and I was like, the patient's not vomiting and the blood pressure is low. Let's hold off on intubating right now, right? Because if not, they would have done this. They would have gone in, they would have pushed the medications, and you know, the patient would have gone even more unresponsive. And then they would have gone in with their tube and said, all right, you know what, the tube is in. And what do you think the next blood pressure would have come back at? Yeah, right? Dead over dead, you know, 50 over 30. So yeah, dead. And so when you rewind this and you look at the situation, there's very telling things that you can see that are going to cause this patient to collapse as soon as we introduce them to positive pressure, as soon as we take that 9 Inch Nails survival song and turn it into Bob Marley with ketamine. Like, when all those things are going to cause this patient to not mount that sympathetic response. And actually one of the talks that we're doing tomorrow is on that exact thing. So I said, let's hold off and let's not intubate. And we'll get some blood. If we need to intubate in the helicopter, we can. But I have a feeling she's unresponsive because her blood pressure is so low, right? So we get her in the helicopter, and it's not fun to intubate in a helicopter. So I'm really hoping we don't have to. But I start giving some whole blood. We're giving plasma. And we get the blood pressure up to like in the 80s, 90s. Heart rate starts coming down. And the patient wakes up. And she's like, where am I? Like, talking, making sense. And I'm like, That's something I would not have seen if I would have intubated, right? I would have been like, oh no, she's waking up, we got to give her more, like you would not have seen that happen. And that doesn't fit any mental model that I had seen, but we have had a lot of training and simulation on the same exact thing. I'm not used to patients being in a trauma, unresponsive, me deciding not to intubate them, and then them waking up in transport just because we elevated their blood pressure. But it was the right thing to do. I remember another situation, we had a guy that got beat up with a baseball bat, and we get there, his head's all swollen, and I'm talking to him, and he's just staring at me like this. And I'm like, okay, like, can you hear me? What's your name? And he's just like, kind of like this. And I'm like, all right, we're going to have to intubate him, so get him in the back of the ambulance, get all of our meds drawn up, and we're getting ready to intubate. We're getting ready to push the meds, and he looks over at me, and all he did was this. He just went like, and I'm like, all right, that was spooky. Like, that seemed purposeful as hell. Like, and I'm like, I don't know, like maybe he just doesn't, something's like he maybe doesn't speak English, like, so I'm like, guys, hold off on intubating. And you can get this like diagnostic momentum, or even I think they call it sunk cost fallacy. You guys ever heard of that before? It's like when you go to the elevator and you hit the button and you're waiting for the elevator and you're like, okay, at this point I could have taken the steps, but I've already spent so much time waiting for the elevator that I'm going to keep waiting. And you're waiting, and you're like, well, now I could have gone up the steps up and down twice, but as soon as I walk away, the elevator's going to open up. You can commit yourself to a decision so much that you don't want to go back, right? It looks like going back is you doubting yourself, and your team's going to doubt you. And I was like, all right, this seems really weird, guys. We've already drawn up all of our meds, but I do not want to intubate this guy. I was like, I feel like he's with it. I just think he's scared or something, And they're like, okay. I could tell the nurse was like, what the hell are you doing? Yeah. So we go and get him to the hospital, and they bring in an interpreter, and the dude was singing like a bird. I mean, he was talking like up a storm. He was just scared. I mean, some farmer came in and beat the snot out of him with a baseball bat, and he just wasn't communicating with us. But it was like, you can't intubate someone because they don't speak English, right? But you know what? Here's the thing. So both of those mental models are playing, and I'm like, okay, like, sometimes you don't intubate people. Sometimes you just leave it alone, right? So I come in on another call, get in the back of the ambulance, and there's like 5 firefighters holding this guy down. And they're like, motorcycle accident, head trauma, he's combative, you're gonna need to intubate him. And I'm looking at him and I'm like, maybe he's just claustrophobic. And I'm already on, I got these other calls in my head. I'm like, maybe he's just claustrophobic. And I'm like, everybody just let go of him for a second and see if he stops fighting you. And they're like, he's gonna rip his IVs out if you do that. And I'm like, no, guys, I've seen this before. Like, just let go. And so they're like, oh my God, okay. And they all let go. And the guy goes, I'm like, all right, everybody back on. And the nurse looks over. She's like, did that go how you thought it was going to? And I was like, no, we're going to need to tube him. So it doesn't always work, but it was interesting because I was like, if this works, I'm going to be on a roll. It's the hat trick. I got 3 patients, and I was like, wait, maybe we shouldn't intubate. And so I was like, I want to build up those experiences so I can, walk in and say, yeah, here's that PEEP valve, and that, feel like I'm really good at my job, and, throw the PEEP valve to the new provider and then throw it on. Or when you got the car that's rolled over, I want to be the person that comes in and says, yeah, what was the glucose on that patient? I want to try to take this, and I want to skip over all of these and get to this point. Well, after doing this for, 13, 15 years or so, your job now, you kind of already waited on the experience, right? But our job now is to try to teach future providers how to do this, how to avoid all of those hassles and those learning points, and not avoid the learning points, I should say, but avoid feeling like this isn't for you. How do you do that? And so I came up with this thing I call the path to conquering the wicked. And the reason I call it wicked, and the first thing to understand, is that the environment that we practice in is considered a wicked environment. So there's 2 different types of environments. You have a kind environment, and then you have a wicked environment. Have you guys ever heard those terms before? So a kind environment is one in which the feedback you get is really quick and it's accurate. For example, I sit down, I'm getting ready to hit a golf ball. I hit it, boom, I see that the golf ball went off. I sliced it, whatever. I don't golf, so I don't know which is a slice and a hook, but you immediately know it, right? And then you look at our environment and we do things and we hope we did the right thing. The follow-up is sometimes delayed, not there at all. And we could sit there and I could have intubated that patient who didn't speak English and dropped him off. And do you think I would have ever known anything about that? No, not at all. I mean, I had every reason to intubate him. And they would have woke him up and then he would have, they would have discharged him. And I would have thought, I'm perfect. I'm nailing this, right? I got the tube. I did all the things that I was supposed to do. You could have a patient that you just couldn't get capture on and you kept turning it up. And if you don't stick around and ask, well, what does the hospital do? And I always tell people, if you drop off a patient and the physician does something within like 5 to 10 minutes and you are able to do that, you probably should have done it. And one of my best pieces of advice for like new people is when you drop off a patient, once all of the rigmarole slows down, walk up to the doctor, even the nurse, and say, is there anything that I didn't do that you would have done? I've gotten the most valuable feedback at that point. Instead of just, all right, thank you, sign this and head out, just asking them, what would you have done differently? And sometimes they'll say nothing. And that feels really good. When you have a physician or a nurse or trauma physician in there, and I drop off a really sick patient and I go, what would you have done differently? And they say nothing. I'm like, sweet, but even better is when they go, well, you know what, I would have done this and this and this. You guys gave, 3 to 4 units of blood. You probably should have given some calcium with that as well. Or, it wouldn't hurt to give some TXA with this. And you take that advice and you're like, cool, I can store that away for next time. But that's like such a valuable feedback, because have you guys ever tried to call the hospital later and get a follow-up and they act like you're a terrorist from another country and they're like, well, who is this? And you're like, I literally was just eating peanut butter and jelly sandwiches in your ER bay. Like, you don't remember me? And they act like, whatever. So the kind versus wicked, there are skills that are kind, right? We know if we get an IV or not right away. But the majority of what we do that really makes patient impact is wicked. And so, you look at a skill like intubation, for example. Is this a kind or a wicked skill? Yeah, you would think it's kind, the actual skill, right? But when it comes to like the decision to actually intubate, then that is that's going to be more wicked, right? Because I don't know if I made the right choice with that. I would hope so, but if I intubate, I don't know. And so there's a lot of things that we do that are that wicked side of the equation. And for example, things that we do in EMS program our brain to think in these mental models. For example, say you're working a cardiac arrest, right? And we go in and we start CPR. All right, cool. We're doing CPR. And then we give some epi, right? So epi is in. And then we give some bicarb, right? Because of prolonged downtime. And then the patient gets a pulse back. If you do this, there's always a tendency to think that the last thing you did is the thing that actually brought the patient back, right? And so then everybody has a new profound love for bicarb because it was the last thing you gave before you're given tons of epi. And the problem is you have to see this on a larger scale in order for it to actually represent the probability. For example, have you guys ever seen these weird correlations online? Like, for example, this is the age of Miss America compared to murders by steam, hot vapor, and hot objects. I don't know what happened in 2008, but this one's even better. This is the divorce rates in Maine correlates with the per capita consumption of margarine. So just because you do something and it seems like that's what worked, that doesn't make it the actual case, right? Like, you have to look at the evidence. You have to look at what the latest studies are showing. because your small sample size of the patients you see, that's part of what makes that wicked environment, is you're only looking at these 3 situations, or 4, or, how many cardiac arrests you run in your, let's say in a year or 2. You can start forming these biases because you've seen things work when in fact they may not work at all, right? So if I take a quarter and I flip it and it lands on heads, and then I flip it again and it lands on heads, and I flip it again and it lands on heads, does that mean that there's something wrong with the coin? What's the chance that it's going to land on heads versus tails? 50-50, right? So if I flip it 3 times and it lands on heads every time, what's the problem? A double-headed coin. What if that was the point I was trying to make? You need to check both sides of your coin. No, it means you haven't flipped it enough, right? We haven't flipped the coin enough to actually see the true probability. There's something called the theory of large numbers, right? So you have to do it a bunch of times in order for that to actually start to correlate. I love the delay with this. Like, I swear these animations are so much better on when I'm actually connected to the projector. But yeah, you may have some that go up to heads, some that go down to tails, but eventually if you keep flipping it, you should see what the actual probability is. So if you're trying to decide whether patients in cardiac arrest need bicarb, and you give it to a patient and they come back, and then you give it to another one and they come back, you could go, wow, I don't understand why. Do you guys know the AHA came out and said we do not recommend the routine use of bicarb anymore? Literally, it's been for the last like 4 or 5 years they said that. But we keep seeing people do it, right? Is there anything else? Well, I guess we could give them some bicarb. And it's because we've seen it work on a couple of people. So our mental model gets framed that, oh, this should work, right? But if you go get these studies where they did it on 5,000, 10,000 people, you go, oh, it doesn't. I just didn't flip the coin long enough or as many times. And I think that's interesting. And so if part of being a provider is not waiting for something to appear in a textbook before you adopt it. It's having some sort of system to where you can dig into the literature. And there's a lot of like really good blogs and podcasts that take those long papers and then try to like put them into a digestible thing that you can take away from. FOAMFRAT, which is the company I started, stood for Free Open Access Medical Education for Resuscitation and Training. And we thought, let's read these boring papers and then put them, because I know how EMS providers are, right? They want pictures and they want stuff to look good. And let's translate this so that way we can get out this new evidence-based medicine, this EBM, instead of just doing things because that's the way we've always done them. And so I encourage you guys all, if you can, just maybe it's Monday morning, you pick one journal, or you go to FOAMFRAT and check out one of our newest blogs on placenta previa and some of the new treatments with that. Or, we just did one on how to implement ultrasound within your program and what are the biggest things that prevent people from using ultrasound. But have a source, have a couple of sources that you pull from and just try to just stay up to date with it. That's what these conferences are for too. But the problem is we don't have enough conferences throughout the year. If you wait till one time a year to update your mental model, it's hard. Think how many iPhone updates you've had to do within a year or so. So you got to constantly do that. And part of that comes down to accurate self-reflection. We, and you probably aren't going to hear the sound on this, but we started making this like online series. My dream, and you'll hear this in the talk I do at noon, but when I was younger, my dream was to be a Disney Pixar animator. So I wanted to work and storyboard and create these animations. And so I thought we should do a whole little cartoon segment on accurate self-reflection. And so in that, and this is going to glitch real bad, but we came up with these 2 characters, right? So you have Paul over here, and so he's cleaning the monitor off, and he says to Wayne, "Don't beat yourself up, kid. We didn't have enough time. The hospital was only 10 minutes down the road." And it's a little slow on the refresh rate, but the lip syncing was perfectly animated. And I thought, this is something we've all heard, right? Are you sure we shouldn't have done that? Why? The hospital's right down the road. We just get them to the hospital, kid. That's what our job is. We just get them to the hospital. And I made this little graph, and it was like the decision making on whether you should do an intervention. And it said, Are you close to the hospital? And, it said, the first thing was said, does the patient require the intervention? And it said, yes. And it said, are you close to the hospital? And it said, yes. And it said, do the intervention. And then on the one, no, it still said, do the intervention. So the geography between the ambulance and the hospital should not dictate whether you give that femur fracture some pain meds or whether you do a 12 lead on that patient. Like, we worked up to our skill level. And just getting them to the hospital, I think we've all seen hospitals that are a well-lit scene call, right? Like, it's maybe they don't have everything perfectly dialed in. You and your partner are likely the best thing when it comes to using your scope of practice to treat your patients to that level. And so part of the critical self-appraisal is making sure you're not falling into these biases, sunk cost fallacies. There's a whole list of logical fallacies. And I always like to go through them because it's like it is human nature to fall into at least a few of those, especially when you look at how we work and what we do in our job. Like, we are constantly in situations where we can frame a mental model completely wrong, and then we'll never get the feedback back on that. Stopping and saying to the physician, is there anything else you would have done? That's a huge one. Adopt that, looking at like evidence-based medicine as well. And then the last one, not the last one, but is embracing simulation. So, does anybody here do simulation? What does simulation look like at your shop? Mm-hmm. Yeah, we do a ton of simulation at LifeLink. It's quarterly. So every quarter we come in, they give us our call. We come walking in, there's cameras everywhere, as you got an educator that's kind of grading like the certain high points on it. And we treat it just like it's an actual call. Like, we have a lot of buy-in from everyone because we know, like, this is how we're training our mental models, right? I had one where it was a patient who overdosed on a calcium channel blocker. And I was like, oh, high dose insulin therapy. This is perfect. And I set up my high dose insulin therapy, and I could tell, I'm like, all right, I'm going to need like 4 liters of insulin for the transport. And my partner's like, anytime you have to ask for something that seems abnormal, you probably need to check your math on it. And I'm like, I mean 100 ml bag of it. But it's like, I want to make those mistakes in that simulation. So if you're not doing simulation, or maybe you don't have the budget to buy some, $1 million Laerdal mannequin and set it up, you can do something called shadow boxing, which is really interesting. It's where you play a scenario, and then you have maybe a group of experienced providers, and then you have a group of new providers. And you have the new providers first watch a clip, right? And they say what they would do, and then you compare it to these people over here. And so one of these is a scenario we did online, another animation I'm going to make you guys sit through. But I said, watch this clip, and then I want to ask you some questions, right? So I'm going to play it, you guys watch it, and then I'm going to ask you some questions on the scenario.
Oh, thank God, this guy has a massive pulmonary embolism and needs a thrombectomy immediately. You guys got to get going.
You can see my Pixar inspiration in here. So we go in, we look at the guy. He's now intubated, came in with shortness of breath. Blood pressure 50/30, SpO2 at 86, heart rate of 53. There's the ventilator settings. And this is on YouTube too, if you guys want to watch it without the refresh rate all slipping like that. The foam frat mug. So we got heparin and levofed running. So I played this, and then you don't need the music in the background and all that either. You could just take pictures or whatever. But I would ask, All right, so obviously this guy's got a critical pulmonary embolism, right? Did you see any signs in the beginning that made you think that that's probably a pulmonary embolism? See the travel of the parking ticket floating around in the bottom of the car? So we'll put little Easter eggs in there. And then the physician is like, you guys got to get going. But here's the other weird thing. The blood pressure was really low, but so was the heart rate, right? The heart rate was like in the 50s. So you play a clip of something. If you don't have an expensive Laerdal mannequin, we put a lot of these out just on YouTube. So you could go, oh, let's use the foam frat OB one or the foam frat, and they're free to use. Play it for your training room, and then have that discussion and be like, how would you guys fix this? Would you go up on the Levofed, or would you add on epinephrine? Do you think we should start like TPA or TNK on this guy? And you can lead to some really good discussion. And it doesn't have to be advanced like that. It could be somebody bagging a patient and saying, we can't get the SpO2 up. And then you ask, what would you guys do? Well, is the oxygen on? Yeah. Bag faster, right? And then somebody says, well, where's the PEEP valve? And so you can do these little shadow boxing cases, and it helps out a lot. Another thing I did when I started flying was I would record myself doing different interventions. I'd set up the camera up inside the helicopter, and I was just going over like starting a Levofed drip, right? But it's like everything's in weird spots in the helicopter. And so I would have how I currently do it, and then I would ask, well, how can I do it better? And then me and my partner would actually record ourselves practicing this and how we would go through that skill, and then watching it back almost like a high school football coach and being like, is there something I could have done better? So when you're intubating, set your camera up, right? Say maybe every month I'm going to record myself doing an intubation or putting in an iGel or doing CPR, and then go back and watch that and be like, oh, that looks really good. Like I look like I know what I'm doing. Or, oh, wow, like I reached for a ton of stuff and didn't end up using it. That's really common in EMS. I remember my instructor said, all right, guys, we're going to do a simulation. However, if you grab a piece of the equipment and you don't use it, you're not allowed to use it for the rest of the simulation. And so you can imagine by the end of paramedic students, right, we had the little suction for the baby, and the bulb suction, that was all we could use. Yeah, or the other thing we did is we had a patient who was had chest pain, and they were sitting in a chair like right here, right? And so I came in and I put my bag down, and I went and I grabbed my my blood pressure cuff, right? And I went over here and I started taking a blood pressure on him. And then I needed something else. I walked over here and I grabbed my bag, and then I walked back over here. And I didn't realize until I watched it later on, and I'm like, why didn't I just move the bag, right? There's a tendency to think where you put the bag in the beginning of the call is where it stays. It does not move anywhere else. Or we did a simulation with the kid. It was a mass casualty, and they had the parent over here, one person, kid was ejected over here. And so my partner goes to the parent, I go to the kid, and we're throwing stuff back and forth with each other. And they're like, at any point, did you think about picking up this kid and just moving it closer to all of your stuff? And it's like, I guess when I watched that, I'm like, yeah, why did we do that? But it's something, if you don't actually watch it or have coaching, you wouldn't know that, A new thing that we're doing on Foam Frat is we're doing this segment called Procedure Prepper. And the idea is I've never done a blank, but this is how I'm preparing. So somebody came up to us and said, we need training on hysterectomy, resuscitative hysterectomy. And I'm like, or hysterotomy. And I'm like, okay, I don't know any paramedics that's in their scope of practice, but apparently somewhere out west, they're doing these, right? So if mom goes into cardiac arrest, they'll go in there and cut her open and take the baby out. And so I asked my medical director, I said, we need to do a video on this and how training. And she's like, I've never done one. She's like, I'm not going to teach on something I've never done before. And I go, I think that's the angle. I've never done a blank, but this is how I'm preparing. So what we're going to do is bring on someone who has done that, and then bring on her. She's going to say how she's training, and then have this person fill in the blanks, right? So you may have somebody, like the map, I imagine, probably looks like this. Like you have the novice and how they've learned to get to that skill or how they think they should prepare. And then an expert comes in and says, actually, you can cut all of that, and this is what you actually should see. And this is how you should fill in those buckets and try to reshape that mental model. So you're going to be seeing those come out on Foam Frat. We're going to do intubation, IVs. Like we want to get new paramedic students who have never intubated a patient And then I'm going to bring on like Dr. Jim DeCanto, an anesthesiologist who's intubated, thousands of patients, and have them go, well, I'm practicing on this mannequin, I'm practicing laying down on my chest with my hat backwards, and like how, and then I want him to be like, listen, practicing intubating upside down in your classroom is baloney. Like, don't do that. Get them into the ambulance and intubate when you can get them positioned properly, and try to cut down on some of the things that we do in EMS school. Have you guys ever seen those airway gauntlets where they're intubating in a garbage can upside down? It's like you are training people to think that they have to intubate in the position they find the patient. And my solution is put an iGel in, get them out, get them in a well-lit ambulance, suction, whatever, if you can, and just do it right there. So I think it's the way that we train students in paramedic school or EMT school has a lasting impact, right? There's a tendency, we all think that if you give a patient nitro before doing a 12 lead, it's going to be an inferior wall MI, and your patient's going to go into cardiac arrest, right? Because that's how every simulation in paramedic school went if you didn't do in the other order. So as much as mental models can like really help us, they also, if we don't do them right, or we have a coach that is putting in bad information, bad inputs, it's going to reflect in the performance, and it's going to just really frustrate those providers. So I really appreciate talking with you guys this morning. We're going to get into some more stuff on education and art and animation and how to bring this stuff into your training room at the fire department. My goal for this talk is for, if you guys walk away with anything, it's to understand the concept of a mental model and understand that we perform largely in a wicked environment where the feedback is delayed and often inaccurate. So what are you doing to try to make sure that the feedback that you get is accurate? What are you doing to look at your, the latest evidence, the latest papers and stuff that come out? So that way, just as fast as everybody looked at this and saw, still not loud enough. As fast as you guys were able to come up with mental simulations and recognize those abnormal behaviors, you'll be able to do the same thing. You'll throw someone else a PEEP valve. You'll throw them calcium chloride before the labs come back. You'll ask them, hey, did you check a blood glucose? Because you'll have these things all programmed in your mind. All right, guys. Thank you guys so much. I appreciate it. This is my email here, so you guys feel free to email me if you want any of the slides, videos, any of that stuff. And a shameless plug for foamfrat.com.
You have these for like CPR.
Like what?
Well, I'm a CPR instructor.
Oh yeah.
Some of this would be really.
I don't know if we have anything for CPR specifically. Maybe we do. If you send me an email,
I will.
yeah, I'll send you some of the stuff I think. Yeah, absolutely, sir.